Hi students, welcome to NEET-PG 2021 ADRPLEXUS Analysis of Pathology Questions. So I am Dr. Vimal, MD Pathology from CMC Vellore and as a Professor of Pathology. So now, first, we'll have an overview about that NEET-PG 2021. How was the exam? Like the view from most of you is it was a relatively easy paper. Like compared to previous NEET 2020, actually many students felt that this is a relatively easy paper. Though the questions were, some questions were like a lengthy, like with a long history, like equal proportion of students felt that there are some direct questions and straightforward questions which were equally seen. So actually, if you see the questions, more number of questions are now coming from pathology, ENT, ophthalmology, high. Okay, there are more number of questions from these subjects. So what is the thing is, this same pattern may reflect in the upcoming INICET or in the upcoming next exams also. So nowadays they're starting more questions from pathology, ENT and ophthalmology. So if I see from analysis from pathology point of view, so there are direct questions from pathology if you take, actually there are some nearly 21 questions which are direct questions from pathology. And overlapping with other subjects like OB-GYN or the radiology or from other medicine. So other subjects, if you see that overlapping the questions, that counts to nine questions. So a total of 30 questions. So a total of 30 questions appeared in at present this NEET exams. So if you compare these with the 2020 NEET, actually out of these 300 questions, there were some 25 pathology questions. Now, if you see out of these 200 questions, there are some 30 pathology questions out there. So actually, now they are giving more increasing weightage to the pathology. So now if you see the analysis of questions as a chapter wise or like a thing wise, if you see this, from general pathology, you have, they have asked now 7 questions. So from the cell as a unit of health and disease, that basic structure of the cell, they have asked one applied question. And from cell injury and adaptations, one applied question was asked. And inflammation, one question was asked, the 2 applied. And genetics, one applied questions was asked. And neoplasia, there were 3 questions asked and 2 were applied and only 1 was a recall type of question. So actually most of the questions are of applied type of questions. So if you see the topic wise, the general where we have to concentrate, we have to concentrate for the upcoming exams. They have asked from cytoskeleton, pigments, cytokines, lysosomal storage disorders. They have asked one question, molecular basis of cancer, chemical carcinogenesis, and in the diagnosis of cancer, they asked one question. So out of this general pathology, 7 questions. These are all the distribution of the topics. These are all from these topics only the questions were asked. So if you see hematology, even in hematology also they have asked 7 questions. In RBC disorders, they have asked more questions. All these questions were applied questions. Okay, please remember. So in hematology, all the questions were applied questions. And from RBC disorders, 3 questions they have asked. WBC disorders, 2 questions. And miscellaneous topics like aplastic anemia and multiple myeloma, 2 questions were asked. And in clinical pathology, in the lab safety, they have asked 1 question. So in the topic wise, if you see, in the hematology, from iron deficiency anemia, 1 question came. Megaloblastic anemia, 1 more question came. Pure red cell aplasia, chronic myeloid leukemia, non-Hodgkin's lymphoma, aplastic anemia, multiple myeloma, and lab safety. These are all the topics from where they have asked questions from the hematology. So if you see systemic pathology, even in the systemic pathology, if you see the 21 questions of pathology, they have given equally distribution. Okay, general part 7 questions, hematology 7 questions, and systemic pathology 7 questions. Okay, so blood vessels, they have asked 2 questions, heart 1, kidney 1, bladder 1, eye and skin each. Okay, so all these are all applied questions. So please remember students, now the pattern is like it is fully of applied questions. Okay, so no direct questions, though direct questions maybe 1 or 2 questions, but most of the questions are applied questions where you have to apply the concept which we have learned. Okay, so in the blood vessels, if you see, in from vasculitis, actually they have asked 2 questions, and in rheumatic heart disease, nephrotic syndrome, bladder cancer, retinoblastoma, bullous lesions of skin. So this is the post-mortem of these questions asked from the pathology. So you now know this. These are all the high-yielding topics. Okay. So it is not only from this 2021 I am discussing these topics. Actually, previous year papers, if you carefully see, observe the previous year question papers, actually these are all the most repeated topics. Okay. These are all the most repeated topics, and most high-yield questions are asked from repeatedly from these topics. Okay. These are all the examiner's favorite questions. Okay. And if you see the image-based questions, there were 4 image-based questions from pathology subject. Okay, so either they have given the histopathological image or a gross image, and they have asked you to diagnose the disease with the help of the history. Okay, so this again insists us the importance of concentrating on the gross images and the histopathological images. Okay, so pathology is actually a picture based subject. Okay, an image based, a view based subject. Okay, so they have given equal importance. So image based questions, 4 questions were asked. So this will be the pattern which will be continued for the upcoming exams. Okay, so what we have understood, though they have given equal importance to general parts, hematology and systemic pathology, and most of the questions were applied questions, and it is image based questions also they have given importance. Okay, and the weightage of pathology is increasing day by day in the upcoming examinations. Okay, so having an overview of this type of questions and weightage of the topics. Okay, now we will let us move on to our discussion on the questions. Okay, so discussion of the questions asked in our exam. So the first question, if you see, the question is, a chronic alcoholic patient presented with increased abdominal girth, decreased liver span. So if you see, he is a chronic alcoholic patient, and what has happened is abdominal girth has increased. So the patient has now presented with ascites. Okay, so it is ascites. So they are given alcoholic patient presented with ascites, and he is having a decreased liver span. Okay, this indicates that cirrhosis has developed. Okay, so the liver span has reduced. So, but now the question is, the liver biopsy is now showing an intracytoplasmic eosinophilic material in the hepatocytes. Okay, see this. This is that hepatocyte which they have asked eosinophilic inclusion material. Okay, it is inside the cytoplasm. Okay, this is inside the cytoplasm. So it is an intracytoplasmic eosinophilic material. Intracytoplasmic eosinophilic material. And they have said that this material is cytokeratin positive. Okay, CK positive. And now they have asked is, what is this element? Okay, whether it is actin or microtubules or fibronectin or intermediate filaments. Okay, so actually this is an histopathological image. Okay, this is an histopathological image, and the finding they have highlighted is Mallory hyaline Denk bodies. So these bodies are seen in the hepatocytes. Actually, what are these bodies? And they have said that these bodies is CK positive. CK positive. Okay, CK positive material. It is usually the intermediate filaments. Okay, usually the intermediate filaments. So CK positive, it is CK8 and CK18 positive. CK8 and CK18 positive. This Mallory hyaline Denk bodies. Okay, these are the intermediate filaments. Now, what can be the future questions from these topics? What are all the other intermediate filaments? Okay, other intermediate filaments. Apart from this, you have this desmin, vimentin. Okay, so apart from this cytokeratin positive material, the other intermediate filaments are desmin and vimentin. Cytoskeleton. What are these cytokeratin? Actually, these intermediate filaments are nothing but these are the cytoskeleton. That is, they give the shape and morphology to the cell. Okay, like we have a normal body with bones and this giving the shape. A cell, each cell has a cytoskeleton. Actually, these are all the cytoskeleton elements. Okay, so but please remember, students, this Mallory hyaline Denk bodies, actually it is a non-specific. Though it is seen in alcoholic patients, this thing also can be seen in non-alcoholic fatty liver disease. Okay, this is a non-specific finding. Mallory Denk bodies can also be seen in non-alcoholic fatty liver disease. It is be seen in alcoholic liver cirrhosis and non-alcoholic fatty liver disease. Also, It is seen in Wilson's disease. It is seen in Wilson's disease. Alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin deficiency. And also Indian childhood cirrhosis. So all these conditions, you can see this Mallory-Hyland dengue bodies. Okay, so it is an intermediate filaments CK8 and CK18 positive. Okay, commonly seen in alcoholic liver cirrhosis, alcoholic hepatitis, especially in the stage, and can be seen in other conditions also. Okay, so now let us move on to the other question. A patient presented with features of squamous cell carcinoma of the lung. Pneumonectomy was done and the hilar lymph nodes appeared blackish. And the pigment responsible is, the options they have given are hemosiderin, anthracotic, lipofuscin, melanin. Okay, so straight away, actually, this is a question dealing from the chapter pigments. Okay, so they have asked, this pigment appears in the blackish in color. This pigment appears blackish in color, and usually they are seen in the hilar lymph nodes. Okay, so and they have said that this is a specimen of the lung. So lung specimen with a blackish pigment. Okay, the first thing we have to think of is anthracotic pigment. Okay, the first thing you have to think of is the anthracotic pigment, which is nothing but the inhaled carbon particles. Okay, the inhaled carbon particles which are appearing as a blackish in color. Okay, anthracotic pigment. Okay, then hemosiderin pigment, where you will get in case of any trauma or injury or iron overload conditions. Okay, like in thalassemia, all these conditions you will get hemosiderin accumulation. What is the stain for hemosiderin? You have to remember Prussian blue. Okay, Prussian blue. And coming to lipofuscin, what is lipofuscin? Lipofuscin is the wear and tear pigment. Okay, lipofuscin is the wear and tear pigment. Okay, it is actually a telltale sign of free radical mediated injury. It is an aging pigment. As age advances, our body is susceptible to the free radical mediated injury, and lipofuscin is a telltale sign of the free radical mediated injury. Okay, so all this lipofuscin will appear which color? It will be appearing as a golden brown in color. It will be appearing as golden brown in color. And melanin pigment. So melanin pigment, it will be a brownish to blackish in appearance. And the stain for melanin pigment, you have to remember this Masson Fontana. Masson Fontana is the stain for melanin pigment. Okay. So lipofuscin pigment, please remember it is a wear and tear pigment, aging pigment, telltale sign of free radical mediated injury. It is a brown color pigment, golden brownish in appearance. And another point you have to remember in this lipofuscin is it is usually in a perinuclear in location. Okay, lipofuscin, you have to remember it is a perinuclear. Around the nucleus, this pigment will be deposited. Okay, this pigment. Okay, another MCQ you have to remember with this lipofuscin is that it results in the brown atrophy of the heart. Brown atrophy of the heart. Okay, so all these things can be the future prospective MCQs asked from this pigment topic. Okay, so the answer for this question is it is a blackish pigment and it is anthracotic pigment. The next question is tocilizumab, a newer monoclonal antibody used in the treatment of rheumatoid arthritis, acts against which interleukin? Interleukin 2, 3, 6 or 12. Okay, so the answer for this question is yes, it is interleukin 6. So interleukin 6, which is an important cytokine and against which this tocilizumab is used. And as you know, in COVID, okay, in COVID, this tocilizumab was used, okay, as a lot of prognostic implication was there with the interleukin 6, elevated interleukin 6 carried a poor prognosis, no? So in COVID, so tocilizumab was used in the COVID also, okay. So please remember to IL-6, which is elevated in the rheumatoid arthritis also has a, this tocilizumab was used, okay. So interleukin 6, you have to remember another important point is interleukin 6 also you have to remember in multiple myeloma. Okay, multiple myeloma. Multiple myeloma. So elevated interleukin 6 carries a very poor prognostic factor in a in multiple myeloma. Okay, so the answer for this question is interleukin 6. The next question, an 8-year-old child presents with hepatosplenomegaly. So, and the child also presented with anemia and leukopenia. So they have given the bone marrow biopsy image, okay, bone marrow biopsy image, and they have shown some cells. And they have asked us first the deficiency of which of the following enzymes is most likely to be present in this diagnosis. Okay, so they're not asking us the diagnosis, they are given us the cell, and now they are asking you that which enzyme is deficient. So how the cells are appearing? See this, the cells, the cytoplasm of the cells. What is the picture? Okay, see this. This is the typical appearance of a crumpled tissue paper appearance. Okay, crumpled tissue paper appearance. Okay, crumpled tissue paper appearance. And these cells are called as Gaucher cells. These cells are called as Gaucher cells. Okay, so these cells are called as Gaucher cells, and the disease is Gaucher's disease. So the enzyme deficient in the Gaucher's disease is glucocerebrosidase. Glucocerebrosidase. Okay, so sphingomyelinase is deficient in Niemann-Pick disease. So it is deficient in Niemann-Pick disease. Hexaminidase A is deficient in your Tay-Sachs disease. Tay-Sachs disease. So what can be the future MCQs asked with these topics? Gaucher cells. A question can be asked, what are all the pseudo Gaucher cells? Okay, what are all the pseudo Gaucher cells? Pseudo Gaucher cells. Pseudo Gaucher cells are nothing but they are otherwise called as sea blue histiocytes. Sea blue histiocytes, and they are mainly seen in leukemias. These sea blue histiocytes, that is a pseudo Gaucher cell, they mimic like that of a Gaucher cells, and they are usually seen in leukemias, thalassemias, and in the lymphomas. So all these conditions you can get the pseudo Gaucher cells. Okay, so Gaucher cells will be having a typical crumpled tissue paper appearance, and pseudo Gaucher cells, they mimic like that of a Gaucher cells, and this is usually seen in conditions like leukemias, lymphomas, and thalassemias. Okay, so now with the other things, Niemann-Pick disease, zebra bodies you have to remember. Okay, the enzyme deficient is sphingomyelinase, and electron microscopically you can see the distended lysosomes will be having that zebra body appearance. So zebra bodies can be also seen in Tay-Sachs disease. Okay, Tay-Sachs disease. Okay, so also remember in Tay-Sachs disease you will get this cherry red spot. Okay, so all of these are all the other tangential topics which you have to remember when you are dealing with your one question. Okay, we have to read about the other tangential topics also. Then the next question we'll move on to is familial HNPCC as a defect in base pair excision defect, nucleotide excision repair, mismatch repair gene, and point mutation. Okay, so this is also one of the most repeated questions, and the answer for this is mismatch repair gene. Okay, so HNPCC has a defect in the mismatch repair gene. Okay, so this usually in a familial colonic cancer, this familial HNPCC mutation occurs, and usually it is associated with MSI, that is microsatellite instability. Microsatellite instability, and mismatch repair genes, usually they have a gene mutation in the MSH2 and MLH1 gene. Okay, so these two genes are usually mutated in this familial HNPCC, and you know this familial HNPCC is this, what we call it as Lynch syndrome. Okay, Lynch syndrome. What is this Lynch syndrome? It is associated with the familial cancers. Okay, so the patient will be presenting with, apart from colonic cancer, cancers in the uterus, ovary, ureters, and in the small bowel. So all these areas, actually there will be a familial occurrence of the cancers, and this syndrome is the Lynch syndrome. Okay, so please remember Lynch syndrome, mismatch repair gene, MSI, that is microsatellite instability, and the commonest genes mutated are MSH2 and MLH1. Okay, so what about the sporadic colonic cancer? Sporadic colonic cancer, which is the most commonest type, no, sporadic colonic cancer. So the gene mutated usually in this sporadic colonic cancer is APC gene mutation. Okay, so APC gene mutation. Now you will be knowing this. Where is this APC gene located? It is located at the chromosome 5. Okay, so APC gene located at the chromosome 5, and mutation is causing this FAP. Okay, that is familial adenomatosis polyposis colon. Okay, so these are all the other topics. Okay, so usually if you listen my class, you would be able to understand and easily answer these questions. Okay, familial HNPCC mismatch repair gene defect. Okay, so moving on to the next question. A patient presented with history of fatigue, weight loss, multiple infections, and a history of 20 years of benzene exposure. Okay, so they have given a like occupational hazard. The patient has been exposed to the history of benzene exposure for nearly 20 years. Okay, and systemic examination of the patient was normal, but they are asking, he is most likely to have the carcinoma of which organ, whether it is a bladder, blood, skin, or lung. Actually, there is some controversy, like some students confused with the two options. Okay, they have ruled out easily the skin and lung, but there occurred a confusion between the bladder and the blood options. Okay, please remember students, benzene exposure is associated with blood malignancies. Okay, blood malignancies, leukemias. Okay, leukemia. So benzene exposure, blood. Okay, blood malignancies. Okay, and it is benzidine exposure causes this bladder cancer. Okay, benzidine exposure causes this bladder cancer. Okay, so what are all the other tangential things which you have to learn in this thing? Okay, so please remember aflatoxin. Aflatoxin causes hepatocellular carcinoma. Hepatocellular carcinoma. Asbestosis, yes, yes, it is mesothelioma. Mesothelioma. Okay, so vinyl chloride, thorotrost, all these things will be associated with angiosarcoma and the hepatocellular carcinomas. Okay, so you have to remember about the exposure of the carcinogen and the carcinoma caused by it. Okay, and diethyl stilbosterol, it can result in the adenocarcinoma of the clear cell adenocarcinoma. Clear cell adenocarcinoma of the vagina. Okay, vagina. Diethyl stilbosterol exposure during the pregnancy, a female fetus can present with this clear cell adenocarcinoma of the vagina. Okay, so moving on to the next question. Pap smear of a 21-year-old female revealed squamous epithelial cells with pleomorphic hyperchromatic nuclei, irregular nuclear membrane, and disorganized maturation index involving the entire thickness of the epithelium. This feature is referred to as metaplasia, hyperplasia, dysplasia, or carcinoma. So what does the pap smear show? The pap smear showed the epithelial cells exhibiting pleomorphism. Pleomorphism, different morphology, different size and different shape. Hyperchromatic, okay, the chromatin is very dark, and irregular nuclear membrane, okay, irregular nuclear membrane, but all these things are involving the entire thickness of the epithelium, but please students, but they have nothing mentioned about anything about the invasion into the stroma or this thing. Okay, they have just mentioned only the pap smear. Okay, it is mainly the pap smear description they are describing about this cell. Okay, so from the description itself, you can see that this is a disordered growth. Okay, disordered growth. Okay, the cells are not following any normal rules. Okay, they are pleomorphism, hyperchromatism. Okay, so they are a dysmorphology. So it is a dysplasia. So dysplasia. So the answer for this question is dysplasia. So what is the important thing you have to remember is dysplasia here, it is a carcinoma in situ, that is when it involves the entire thickness of the epithelium, but the basement membrane is intact. Okay, the basement membrane is intact in all these conditions. Okay, but if the basement membrane is breached, what it can be called as? It is called as an invasive carcinoma. So the precursor lesion is carcinoma in situ, where the basement membrane is intact and the epithelial cells are said to be exhibiting the dysplastic changes. Okay, dysplastic changes. Now let us come to this word, disorganized maturation index. What is the maturation index? What is maturation? Actually, if you see the epithelium, the basal layers or the basal cells you have. Okay, the basal layers of the cervix are the basal cells. Then you have the parabasal cells. Then you have the intermediate and the superficial squamous cells. Okay, so it is from these basal cells, the cells move on maturing. Okay, maturing. So these cells, okay, especially the superficial cells and the intermediate cells are hormone responsive cells. Okay, these are all the hormone responsive cells. Superficial is estrogen response and intermediate cells responds to the progesterone. So these are all the hormone responsive cells. So when there is a disorganized maturation index, what happens? This parabasal and the basal cells are not maturing. Okay, the maturation is disorganized. Okay, so say for example, there should be like normally this estrogen phase, superficial cells will be more. Okay, progesterone phase, and also in pregnancy, the intermediate cells will be more. Okay, so that is an organized maturation index. But disorganized maturation index means there is some dysplastic changes occurs. So the cells are not responding to anything. Okay, so that is what the term disorganized maturation index. Okay, so connected with the pap smear, another MCQs which can be future MCQs which can be asked is the precursor lesions. Okay, the precursor lesions, what do you call it as? CAN1, CAN2 and CAN3. So what is CAN1? CAN1 is when the dysplastic epithelium is confined to the lower 1/3 of the cervix. Okay, cervical epithelium. Okay, lower 1/3 of the cervical epithelium. And CAN2 is when half of the epithelium is involved, you call it as a CAN2. And CAN3, when the entire thickness of the epithelium is involved. Okay, that you call it as a CAN3. The next stage will be the carcinoma in situ. So the CAN1 is also otherwise called as LSIL. LSIL. What is LSIL? Low grade squamous intraepithelial lesion. LSIL, low grade squamous intraepithelial lesion. Please students remember, CAN1 corresponds to low grade squamous intraepithelial lesion, LSIL. Now what is the CAN2 and the CAN3 corresponds to? It corresponds to HSIL. HSIL is high grade squamous intraepithelial lesions. High grade squamous intraepithelial lesions. Okay, high grade squamous intraepithelial lesions. Okay, so CAN2 and CAN3 corresponds to high grade squamous intraepithelial lesions. So these are all the prospective future questions which can be asked from this topic. Okay, so now let us move on to the other questions, that is questions asked from the hematology. Okay, so the first question in the hematology they have asked is, all the following parameters are elevated in iron deficiency anemia except. Okay, so the key word you have to remember here is the important word except. Okay, so let us see the options. Total iron binding capacity, transferring saturation, soluble transferring receptor, RBC protoporphyrin. So what happens? So in iron deficiency anemia, total iron binding capacity will be more increased. Okay, body wants to bind the iron. Okay, and definitely the transferrin receptors will be more increased. Okay, to get more iron. Okay, and RBC protoporphyrin, yes, protoporphyrin. Okay, that heme is composed of iron plus porphyrin. So definitely the iron level is low here. So definitely the porphyrin levels are relatively higher. Porphyrin levels are relatively going to be higher. So total iron binding capacity, transferrin receptor and protoporphyrin all will be elevated in iron deficiency anemia except the transferrin saturation. Okay, transferrin saturation, there are no iron. Then how the transferrin transport protein, how it will be getting saturated? So transferrin saturation is going to be less in iron deficiency anemia. All the other parameters will be elevated in iron deficiency anemia. Yes, yes. So this is the question which I often insisted during my classes. So that is, if you take my class notes, you can refer this question. I highlighted, these are the future prospective questions in my classes. So now moving on to the other topic, other question. A software engineer presents to the OPD with complaints of easy fatigability. He gives a long hours of work in front of the computer every day. So software engineer, no, and now do this COVID era. So always with the in front of the computer every day. But the important thing is more intake of junk food and consuming less vegetables and fruits. Okay, so this history is very important. More intake of junk food and consuming less vegetables and fruits. So his CBC reveals hemoglobin of 9 gram per deciliter, that is anemia, and mean corpuscular volume is 126 femtoliters. So MCV is elevated. So MCV is elevated. What do you call that? Anemia. So now hemoglobin is reduced, anemia. So MCV, macrocytic anemia. So it is macrocytic anemia. So now it is now we come to a conclusion. This is a macrocytic anemia. So definitely this hereditary spherocytosis or acute blood loss are ruled out from the options. Okay. So what are the two options only we left out? It is folic acid and cyanocobalamin. Okay. So some students had difficulty in choosing between these two options. Okay. So remember students, actually the cyanocobalamin, okay, the deficiency of cyanocobalamin, okay, cyanocobalamin occurs usually in the vegetarians. Matlab, this cyanocobalamin is usually present in the animal food. Okay, it is present in the animal products. Okay, animal products. So usually cyanocobalamin deficiency occurs in vegetarians. Okay, occurs in vegetarians. Okay, so he is taking junk food. Okay, he's taking junk food. Okay, they're not given whether he's taking non-veg or veg or this thing. Okay, he's taking junk food. But the important history is he's taking less vegetables and fruits. Okay, so please students, please remember folic acid, the rich source of folic acid is these vegetables only, vegetables and less of fruits. Okay, more of vegetables. So since he is taking less vegetables and fruits, and these vegetables are a rich source of folic acid, so we will prefer to choose folic acid as the option rather than the cyanocobalamin. Okay, rather than the cyanocobalamin. Okay, so the answer for this question is folic acid. Okay, so folic acid. Okay, so now move on to the other question. A 65-year-old female patient presented with a mediastinal mass, and investigations revealed pure red cell aplasia, which is not responding to the blood transfusion. What is the most probable diagnosis? So they have given the bronchogenic carcinoma, thymic neoplasm, okay, non-Hodgkin's lymphoma. So the main diagnosis here is the condition is the pure red cell aplasia. Okay, pure red cell aplasia. So it is a condition where the red cells are less in number and it is not responding to the blood transfusion. It is not responding to the blood transfusion. And she is presented with a mediastinal mass. Okay, so even in non-Hodgkin's lymphoma, the bronchogenic carcinoma can present as a mediastinal lesions. Okay, but when it is associated with pure red cell aplasia, the paraneoplastic syndrome, usually it is like a thymic neoplasm. Okay, thymic neoplasm. So the answer for this question is thymoma. That is a thymic neoplasm. Okay, so please remember pure red cell aplasia. What are all the other MCQs which can be asked in this pure red cell aplasia? So parvovirus infection. Parvovirus infection results in this pure red cell aplasia. Okay, so parvovirus infection, and which cells, which precursors this parvovirus usually affects? Usually it affects this P for P, proerythroblast. Okay, proerythroblast. Okay, so this you have to remember parvovirus infection in relation to pure red cell aplasia. Pure red cell aplasia. Now the next question, which is a little bit lengthy, but if it is a lengthy question, don't get frightened, students. Okay, so if it is a lengthy question, the examiner gives you more clues. So actually diagnosis of the lesion is very easy in this type of lengthy questions. Okay, so I'm talking in terms of pathology, diagnosis of the lesions. So it is actually choosing the options is very easy in this type of question. So see this question carefully. An 18-year-old boy presented with gum bleeding. So gum bleeding, easy bruisability, and fever for 1 month. 1 month. Okay, 1 month. So what was the general examination? It was unremarkable, but the patient presented with pallor and petechial rash all over the body. So from the clinical symptom itself, you can see that he's having a bleeding disorder and he's having fever and he's having pallor. Okay, so bleeding, platelet affected, pallor, RBC affected, fever, less WBC affected. So from the clinical history itself, we are getting a picture. Actually, the trilineage cells are having some problem. Okay, so now let us see the investigations. Hemoglobin is only 3 g/% and total leukocyte count is 1500 only. Okay, 1500 only, and platelets 15,000 only. Okay, so the 3 lineage cells are reduced, and the corrected reticulocyte count is only 0.5%. Okay, 0.5%. Macrocytes are seen in the peripheral smear examination, and bone marrow reveals fat globules. Fat globules. So they mean to say that it is fully occupied with fat cells. Fat cells. Okay. So if you have attended my class, you will remember the formula for calculating the cellularity of the bone marrow. The cellularity of the bone marrow is 100 minus age. That is, if the age of the boy is 18 years, the cellularity should be 82%. It should be cellular, and 18% only it should be occupied by fat cells. Okay, 82% it should be occupied by hematopoietic cells, and 18% it is an approximate view. 18% it should be fat cells. But see here, it is almost fully fat globules. Okay, so the hematopoietic cells have been reduced. Okay, so the cellularity has been reduced. Okay, and also absent megakaryocytes. If you see the options, why they have given this term absent megakaryocytes, you will understand. Okay, and they are also clearly saying that there are no immature cells are seen. Okay, so let us see these options. PNH, paroxysmal nocturnal hemoglobinuria. Yes, I agree. There is a pancytopenia with this paroxysmal nocturnal hemoglobinuria, but the marrow will be cellular. Yes, pancytopenia with the cellular marrow. You would have read this paroxysmal nocturnal hemoglobinuria. What is the other option? Myelodysplastic syndrome. Myelodysplastic syndrome. Yes, again, myelodysplastic syndrome, MDS, you will get pancytopenia, but there will be a cellular marrow. So both these options we can easily rule out. Okay, because here the marrow is also hypocellular, fully replaced with this fat cells. Okay, then, and also in myelodysplastic syndrome, name itself, it is a dysplastic cells. Okay, dyserythropoiesis, dysmyelopoiesis, dysmegakaryopoiesis, all these things will be happening. Okay, dysplastic cells will be there in MDS. Okay, but there is no such dysplastic features given in the history. So we are ruling out these two options. Okay, then idiopathic thrombocytopenic purpura, ITP. Usually in the ITP, platelet count will be reduced. Yes, but in the bone marrow, what happened? Bone marrow, there will be increased megakaryocytes. Bone marrow, there will be increased megakaryocytes. Like in hemolytic anemia, you will be having that elevated RBC precursors. No, similarly in ITP, you have elevated megakaryocytes, increased megakaryocytes in the bone marrow. But here they are saying that absent megakaryocytes. So we are ruling out this option also. So, and with the clinical scenario and ruling out the other options, the diagnosis, okay, the correct answer for this is idiopathic acquired aplastic anemia. Idiopathic acquired aplastic anemia. Okay. So I told you, if the question is very big, it is easy for us to get more clues and to make a correct choice. Okay. Now let us see this question. A 50-year-old male complains of easy fatigability for 1 year, mild anemia, massive splenomegaly, hemoglobin 10 g/%, total leukocyte elevated, platelet is also 5 lakhs, neutrophils, eosinophils, and if you see basophils, it is 5. Okay, basophils normally hardly you will see 0 to 1, but you see here you are getting 5 basophils. So basophilia is there. Okay, and your WBC count is elevated. And if you see these cells, myeloblast, myelocyte, band forms. Okay, so all these things are there. So the myeloid erythroid ratio is 18:1. What is the normal myeloid erythroid ratio? The normal myeloid ratio, erythroid ratio is 3:1 to even it can go up to 15:1. Okay, this is the normal myeloid erythroid ratio. But if you can see here the myeloid erythroid ratio is 18:1. So the myeloid cells is elevated. Okay, so the myeloid precursors are elevated. So with this, you would have now come to a conclusion. And also one more important clue, massive splenomegaly. So massive splenomegaly with this myeloid precursor forms, and with this basophilia, the diagnosis is CML. Okay, CML. Now the question is not what is CML. Okay, the question is which is the most sensitive or the next investigation which you can go for in CML. Okay, so if you can see whole body. So now the question asked is the most sensitive investigation for diagnosis of these conditions. Whole body PET CT is of no use in this CML. Okay, nowadays. And the leukocyte alkaline phosphatase, we are not using it. And the immunophenotyping, actually it will tell you only the lineage of the cell. It will tell you only the lineage of the cell, whether it is a myeloid lineage or a lymphoid lineage. Okay, so the best investigation, so the next sensitive investigation is fish with PCR. Okay, fish with PCR will detect this Philadelphia chromosome translocation 922, and this can serve as a prognostic factor also, like after treatment also, how the tumor cells have responded. So that also as a prognostic factor also, this fish. And appropriate answer for this question is fish with PCR. Okay, fish with PCR. So the next question, a patient presented with OPD with generalized weakness, fatigue, and lymphadenopathy. His CBC and peripheral blood examination was normal. Biopsy of the lymph node showed diffuse effacement of the architecture and atypical lymphoid cells with indented nucleus and prominent nucleolus. And these cells were positive for BCL2 and CD10. What is the most likely diagnosis? Okay, so now what you can see, the patient is now presented with a generalized weakness, tiredness, and lymphadenopathy. So their features, important feature is lymphadenopathy. And they have now seen that peripheral blood examination was normal. And the biopsy of the lymph node shows this word, okay, keyword, diffuse effacement of the architecture. The architecture is diffusely effaced. So there is a problem in the lymph node. Okay, whenever there is a diffuse effacement of the architecture, the diagnosis is usually it is a lymphoma. So now we have come to a conclusion that this is a lymphoma case. Okay, and they have further agreed to it like atypical lymphoid cells. And now what they are saying this, they are describing the lymphoid cells. They are describing the cells as a cells with an indented nucleus. So indented or cleaved nucleus is the cells will be having this type of cleavage. Okay, that is that indented nucleus. These cells are usually this centrocytes. These centrocytes and the centroblast are the germinal center cells. Okay, in the lymph node, the centrocytes and the centroblast are the germinal center cells. So actually these proliferating atypical lymphoid cells are centrocytes and centroblast. Okay, so and they are now saying that these cells are positive for BCL2 and CD10. And now they are asking you what is the type of the lymphoma. Okay, so it is somewhat we have to apply the IHC markers. CD10, yes, CD10 is usually positive in the germinal centers. CD10 is usually positive in the germinal centers, but these normal germinal center cells will not express the BCL2. Okay, so normal germinal center cells will not express the BCL2. If BCL2 is expressed in the germinal center cells, okay, then there will be some translocation. Okay, there will be some translocation 14-18 that is usually seen in the follicular lymphoma. Okay, so BCL2 positive and CD10 positive, the diagnosis is follicular lymphoma. Okay, follicular lymphoma. Where BCL1 will be positive, BCL1 will be positive in the mantle cell lymphoma. BCL1 will be positive in mantle cell lymphoma. Mantle cell lymphoma, you also have to remember it is cyclin D1 positive. Cyclin D1 positive. Cyclin D1 positive. Okay, cyclin D1 positive. Where BCL6 will be positive. BCL6 will be positive in DLBCL. Okay, DLBCL. Okay, DLBCL. And also please remember CLL bar SLL, it is CD23 will be positive. Okay, so please remember BCL2 and CD10 will be positive in follicular lymphoma. Follicular lymphoma. So the diagnosis here is follicular lymphoma. So the next question is poor prognostic factor for multiple myeloma. Multiple myeloma. Actually, they are given as beta-2 microglobulin, hypercalcemia, albumin, and elevated serum creatinine levels. Okay. So if you would have listened my lectures, you can easily make this easy options. So this is actually the foremost poor prognostic factor is beta-2 microglobulin. Okay. So it is less sort of a direct question. Okay. Beta-2 microglobulin. But please students remember hypercalcemia, renal failure with elevated serum creatinine levels, all these things are also and prognostic factors. Okay, and elevated interleukin IL-6. Okay, elevated interleukin IL-6 and all these things, and even this plasma cell leukemia, all these are all poor prognostic factors. But out of this thing, the most important one is the beta-2 microglobulin. Okay, beta-2 microglobulin. What are the markers for plasma cells? It is CD138 and CD38. Okay, are the markers for plasma cells. Okay, plasma cells. So in plasma cells in multiple myeloma, you will be remembering this CRAB symptoms. No, CRAB symptoms. No, C for hypercalcemia, renal failure, A for anemia, and B for bony lesions. So in bone lesions, what you can get? You can get out the punched out appearance. Okay, in the skull, you X-ray skull, you can get the punched out appearance, multiple myeloma. Okay, so and what are the different types of cells you can get in multiple myeloma? It is moth cells. Okay, moth cells. Moth cells are otherwise called as grape cells. Okay, so what happened? This abnormal immunoglobulins, which is now proliferating, is getting deposited in the cell, plasma cells, and different morphological features gives rise to different types of cells in the multiple myeloma. One such cell is the moth cell, which is otherwise called as a grape cells. Okay, grape cells. And also you can get flame cells, and you can get some bodies. What are the bodies? Gaucher bodies, Russell bodies. So Gaucher bodies, Russell bodies, moth cells, grape cells, flame cells, all these things are associated with this multiple myeloma. Gaucher bodies, usually it is intranuclear inclusion. Russell bodies, it is cytoplasmic. Okay, cytoplasmic inclusion. How you can remember? Gaucher bodies, it is DNA, D for DNA. So it is intranuclear inclusion. So these are all the other questions which can be future prospective questions which can be asked in the multiple myeloma. Okay, so now let us move on to the other question. An intern, while collecting the blood, spilled the blood over the floor. What should be the next step? Actually, those people who have attended this INICET and the future past exams, it is actually, they will easily know that this is actually a very repeated question, often repeated question. And the first thing to manage whenever there is a blood spill is treat it with 1% sodium hypochlorite solution. Okay, though it looks like an applied question, actually this is a commonest fact. Okay, even in your internship or even in your working doing any aware, you will be, this is a commonest thing in the lab which you have to know. Okay, treat the blood spill with 1% sodium hypochlorite solution. Okay, yes. Now let us move on to the questions from the systemic pathology. A 25-year-old female presented with weak pulses in the upper limb and blood pressure 90/60 millimeter of mercury. Her vision was decreased and retinal hemorrhages was present. Okay, so now the female, she is a female and 25-year-old, weak pulses in the upper limb, weak pulses in the upper limb, and BP is also 90/60. So what is coming to your mind? So upper limb pulses are weak. So it is we are dealing with a case of pulseless disease, pulseless disease. And what is another name for pulseless disease? Aortic arch syndrome, aortic arch syndrome. And which vasculitis is now called as this aortic arch syndrome or pulseless disease? It is none other than Takayasu arthritis, Takayasu arthritis. Okay. So the other clinical features which are given in this question is her vision was decreased and retinal hemorrhages were present, Okay. So please students remember this Takayasu arthritis and giant cell arthritis both are like a large vessel vasculitis and presenting with a granulomatous inflammation. Okay. So Takayasu and giant cell arthritis both are granulomatous vasculitis and they are involving the large vessels. And their symptoms is also almost similar in both these conditions. Luckily, actually, we are not getting having the options of giant cell arthritis in the option. Even if it is in the option, here we have to choose Takayasu arthritis. Why? Because here the age is 25. Okay. So giant cell arthritis, usually it is common in the elderly person. Okay. Above 50 or 55 years, the presentation, if the patient is having the same type of presentation, choose giant cell arthritis. That is other name for giant cell arthritis is temporal arthritis, where the patient presents with tender enlarged temporal artery. Okay. Even blindness is a very dreadful complication in the giant cell arthritis. But here the age is less than 50. Okay. So they are around 25 years old female. So always in the 25 years old female with this weak pulses, prefer Takayasu arthritis. Okay. So Takayasu arthritis will be the ideal correct answer in this question. Yes. Yes. So the next question here is a patient presented with palpable purpura with bilateral knee joint involvement and urine is positive for RBC and protein. So what does the patient present with? The patient presents with palpable purpura, purpuric rashes, palpable purpura, bilateral knee joint involvement, and kidney involvement in the form of urine positive for RBC and protein. So we could get only two options here, Henna-Schulin purpura and idiopathic thrombocytopenic purpura. In ITP idiopathic thrombocytopenic purpura, actually these things will not be involved and the diagnosis of this condition is Henna-Schulin purpura. Actually the tetrad of Henna-Schulin purpura is palpable purpura, abdominal pain, arthralgia, and renal involvement. Okay, this is the tetrad of Henna-Schulin purpura. Okay, so usually it occurs in the children. Okay, and one more future prospective MCQ which you have to remember, which can be asked from this topic Henna-Schulin purpura is deposition of IgA. Okay, so IgA deposition occurs in the vessels. Okay, so if somewhere they have given this IgA deposition in the vessel and vasculitis symptoms, please always think of Henna-Schulin purpura. Okay, and this is the vasculitis. If you could see, there are actually two questions were asked from the topic vasculitis. Okay, remember students, almost every exam, whether it is an INICET or NEET exam, so every exam from vasculitis, minimum one question will be there. Okay, so this is a very high yield topic which I usually insist in my classes. Okay, so please concentrate on vasculitis. Definitely you are going to get an MCQ in every entrance exam. Okay, yes. The next question, a 34-year-old female presented with tachycardia, migratory arthritis of large joints. On examination, a pansystolic murmur is present. And echo revealed a mitral regurgitation, and they have given the image of the cardiac biopsy and they have asked us the diagnosis. So she is a female patient, tachycardia and migratory polyarthritis of the large joints. Yes, migratory polyarthritis of the large joints and cardiac involvement in the form of pansystolic murmur and mitral regurgitation, the commonest valvular disease. Yes, then the condition everybody will know, we now knowing that it is we are dealing with a case of rheumatic heart disease, and they have portrayed this, showed this biopsy image, cardiac biopsy image. Okay, what is this cell? What are these things? Actually, this is the cardiac muscle. Okay, so this is a cardiac muscle, and you can see the structure, and this structure is nothing but it is the Ashkoff body. Ashkoff body. Okay, so what are these individual cells? What are these cells? These cells are nothing but these cells are the Anishkoff cells. Okay, Anishkoff cells. Okay, these are nothing but these Anishkoff cells are nothing but these are also called as caterpillar chromatin. These cells will be having the chromatin in the form of a caterpillar. Okay, so caterpillar cells. On a longitudinal section, this chromatin will be appearing as a caterpillar, and on cross section, this chromatin will be appearing as an owl's eye-like appearance. Okay, so Ashkoff body is the entire collection of the things structure where you have the collection of this Anishkoff cells which are having this caterpillar chromatin in the longitudinal section and owl's eye appearance in the cross section. Okay, so many these Anishkoff cells fuse together form a giant cell, and those cells is called as the Ashkoff cell. Okay, Ashkoff cell, that multinucleated giant cell is the Ashkoff cells, and the entire structure and the phenomenon, that entire pathology is the Ashkoff body. Okay, please remember the type of necrosis which you can see in the Ashkoff body is the fibrinoid necrosis. Fibrinoid necrosis, remember. Okay, in the vasculitis also you will be seeing this fibrinoid necrosis. Okay, fibrinoid necrosis. Okay, so this is a case of rheumatic heart disease, and the image shown is Ashkoff body. Ashkoff body. Okay. So now the next question is, a 10-year-old child presented with generalized edema, and the lab investigations revealed elevated cholesterol. Okay, cholesterol is elevated, urine protein is 3+, and oval fat bodies are seen in the urine, and stool microscopy is positive for fat globules. Yes, so from the features itself, you can now come to a conclusion that it is a case of nephrotic syndrome. So nephrotic syndrome, what I will use to insist in my class, please remember students, nephrotic syndrome. So edema will be more prominent. So edema will be more prominent, that they have highlighted as generalized edema. Yes, and why there is edema? Because there is albuminuria, and hypoalbuminemia, lipiduria. Lipid will be excreted in the urine. Okay, so hyperlipidemia will be there, lipiduria will be there. That's what you get, is urine and stool positive for the fat. Okay, so it is a case of nephrotic syndrome. So the nephritic syndrome, what will be the features? Nephritic syndrome, usually the blood pressure will be elevated. Okay, and one more important thing, it is hematuria. Okay, hematuria, RBC cast and all you will be getting in the nephritic syndrome, like post-streptococcal glomerular nephritis, that no acute infectious glomerular nephritis. All these conditions you will be getting this RBC cast. Okay, that is a nephritic syndrome. So nephrotic syndrome, usually the edema will be more prominent, proteinuria will be more prominent, and lipiduria will be more prominent. Okay, so now tell me students, like what is the most common cause of this nephrotic syndrome in the children? It is minimal change disease. Okay, minimal change disease. That is also a previously asked important repeat MCQ. Okay, minimal change disease is the most common cause of nephrotic syndrome in child. Okay, it is minimal change disease. Okay, now this option, Goodpasture syndrome. Goodpasture syndrome, what will happen? Both lung and kidney will be involved. Okay, because what happens, this antibodies will be produced against the alveolar basement membrane as well as this glomerular basement membrane. So the patient will be presenting with both hematuria as well as hemoptysis. So lung symptoms and kidney symptoms, renal symptoms will be there, but here there is no such history suggestive of these symptoms. So the options of Goodpasture syndrome we are ruling out. Okay. Then the other question is, radical cystoprostatectomy was done in a 75-year-old man, and the gross picture of the specimen is shown below. What is the most likely diagnosis? And see this, actually the very important clue here is the 75-year-old man, radical. Okay, radical. Actually, these students were confused between these two options only, bladder cancer and malakoplakia. Many students told me that, so we got confused with bladder cancer and malakoplakia. But please, students, remember, it is a radical surgery. Radical surgery where they are removing the bladder, prostate, everything they are removing. Okay, so just for malakoplakia, okay, malakoplakia where you will see, remember malakoplakia, Michaelis, Gutman bodies, all this. This is like a localized lesion. Okay, xanthogranulomatosis, localized lesion. So for this, they will not do the remove that entire bladder with the prostate, all this thing. Okay, so and also you can see this is like a proliferative growth occupying the bladder space. Okay, so it is actually a case of proliferative tumor, bladder cancer. Okay, bladder cancer. So this is a gross image. Actually, this is a very commonly seen cases. Okay, so gross image. Then very interesting question and very repeated topic, which I used to repeat these questions in every my classes, during my every sessions. Okay, so a male child presented with Flexner intestinal rosettes. Okay, so they are not asking you to find out the type of rosettes. They are not asking you, they are not giving you the image and asking you what is the type of rosette. They have straight away given that thing. It is a Flexner intestinal rosettes. Okay, so and the ophthalmic examination of the male child showed that white reflex. What is that white reflex? It is a leukoporia, no? So now they are asking is the probable diagnosis. And students, all of you know this. This is a case of retinoblastoma. Retinoblastoma. So coming on to what is rosettes? Rosettes is nothing but it is the concentric arrangement of the tumor cells. Concentric arrangement of the tumor cells is called as rosettes. Okay, rosettes, rose-like concentric arrangement. So what are the different types of rosettes? Flexner intestinal rosettes, which the tumor cells will be arranged in the around the central lumen. Which are the true rosettes? Which are the true rosettes? Around the central lumen, these tumor cells are arranged. Okay, so which are the conditions you will be getting this Flexner intestinal rosettes? You will be getting in retinoblastoma, primitive neuroectodermal tumor, pinealoblastoma, pinealoblastoma. So all these conditions you will be getting this Flexner intestinal rosettes where the tumor cells are arranged around the central lumen. So if there is no lumen, but still the cells are forming a concentric arrangement, then you call that as a pseudo rosette, false rosette. Okay, pseudo rosette. Okay, so where you will see these pseudo rosettes, you have a type of pseudo rosettes called as Homerite pseudo rosette. Homerite pseudo rosettes, where you will be getting this? Homerite pseudo rosettes in the central, you will be getting this neuropil-like element. Around this, you will be seeing this arrangement of the tumor cells. Homerite pseudo rosettes you will be seeing in neuroblastoma. Okay. Then, if you see around a blood vessel concentric arrangement of the cells, that is the perivascular pseudo rosettes. Perivascular pseudo rosettes you will be seeing in ependymoma. Okay, so these are all the different types of rosettes, which is every examiner's favorite question and most repeated question. Okay, most repeated question. Okay, so coming to the abdomyosarcoma, what cells you will be seeing? Myo. Okay, myo means muscle. So what are the muscle cells? Primitive cells. Okay, these cells are called as the strap cells or tadpole cells. Strap cells or tadpole cells. Okay, so strap cells or tadpole cells you will see in rhabdomyosarcoma. Okay, yes. Now moving on to the other question. A patient presented with recurrent bullous lesion over the trunk and arm, which often itself breaks. On histopathological examination, a suprabasal split is observed. Okay, so the bulla is suprabasal bulla and the most likely diagnosis. Students, this is also a very often repeated question. So if it is a suprabasal, okay, coming to the bullous disorders, if it is a suprabasal split, It is none other than Pemphigus vulgaris. Okay, Pemphigus vulgaris. Okay, what is the immunofluorescence finding in this Pemphigus vulgaris? Yes, yes, it is fishnet appearance. So fishnet appearance in the immunofluorescence, suprabasal bulla, the diagnosis is Pemphigus vulgaris. And bullous pemphigoid, where will be the bulla? It will be a subepidermal bulla. Okay, so bullous pemphigoid, the bulla is subepidermal bulla. Okay, subepidermal bulla. So I hope we have discussed pathology questions in detail. So if you are having any doubt, you can post it in the comment box and we are ready to help you. And the overall analysis of this paper, okay, of this paper revealed that most of the questions, almost most of the questions, 95 to 99% of the questions are asked from the repeat topics, okay, high yield repeat topics, okay. Hardly 1 or 2 questions are just out of the box, but most of the questions are like a most often repeated question, which usually I used to tell in the classroom. Okay, so please remember, students, when you start preparing as and when, no, so your topics, you can get more familiarized with the topics, and the high yield topics, if you are familiar with the high yield topics, definitely you can score more marks and get a very good rank. Okay, so wish you all the best, and this is Dr. Vimal signing off on behalf of ADRPLEXUS. Thank you very much.